Yes, my name is Ashley Feighery, and I'm going to talk to you guys today about a very, very important topic near and dear to my heart, outside of asthma, obviously, but it is the early identification and management of non-CF bronchiectasis. So I am excited to talk about bronchiectasis because as a respiratory therapist, right, we all know that big old book, the Egan's book, right, the Bible of Respiratory. We all learned what bronchiectasis is. We somewhat know what it is. But it's not something that we hear often. It's going to be more and more prevalent as it now becomes a primary diagnosis, right? See, bronchiectasis has kind of taken a back seat for many, many years because it's always taken that back seat with COPD. We're now starting to bring it forward as its own primary diagnosis. So I'm excited to talk about it. The research, the money being spent and poured into this disease is going to get even more in the next year as we bring out bronchiectasis guidelines. So there is no guidelines in the United States for bronchiectasis. Of course, there's European guidelines. We are going to see bronchiectasis guidelines being used in the US as early as next year. So I am excited for that, okay? If you guys have any questions, please let me know as we're going along with this. Maybe I should turn it on. All right, so I do need to give you a disclosure statement. I am an employee of Electromade Inc., the makers of the Smart Vest. However, I will keep this non-biased, so I won't talk about Smart Vest at all. I'll use high-frequency chest wall oscillation or vest therapy to describe the therapies that we use for these patients. I am a walker, and the reason I'm a walker is because, believe it or not, I'm only 5 feet tall, okay? Don't let the heels fool you, but most places have a giant podium, okay? I don't like to stand behind the podium. It's intimidating to me. And you all can't see me. You can barely see me, right? Short people, problems. So I love to walk. So I decided years ago that I was going to just kind of TED Talk it, right? And it helps me to connect with the audience. So we all did the DISC training, right? Did you guys learn more and more about yourself? Yes? Maybe more than you wanted to learn? I knew where I was because we actually did this at the company I work with. And so at the end of this, I have a challenge for you. I want you all to tell me where I fall on that disc. And you may already know, but don't say it, okay? My team over there, no. So I want you guys to figure that out, okay? And tell me, because I'm very interested to know where you think I fall. But I do need to give you that disclosure statement for Electromade Inc. So our objectives today are going to be talking about bronchiectasis. I'm going to go over the overview of bronchiectasis, what bronchiectasis is, why is it so important. I'm going to talk about airway clearance therapy. I'm going to talk about getting the pus out, okay? That sounds gross. Are we all respiratory in here? Do I have any nurses? Awesome. The one. Woo. Do I have any sleep techs in here? Okay. So for my respiratory therapist, right, when I say pus, that sounds gross, but we love sputum. Do we? Who loves sputum and who? Right? We love sputum. Maybe not my nurse in the back. I got you. But we do. We love that. And so bronchiectasis is full of it, okay? It's full of pus. It's full of grossness. And I have a doctor that I work with in Sacramento. He said, Ashley, we got to get the pus out. I was like, that's gross, Dr. Louie. But it's true because it smells and it's gross and it's nasty, okay? So why does it fall under COPD? It shouldn't, right? It's its own diagnosis. So we're going to talk about why that's important. We're also going to talk about bronchiectasis, COPD, and NTM because it gets lost in this definition. And it's because of COPD and all that, it's a big umbrella, right? And so we lose sight of what is actually causing the patient to have exacerbations. It may not be the COPD, it may be an undiagnosed, unrecognized disease called bronchiectasis. So I always love to ask respiratory therapists, tell me in this room, can anybody give me the Egan's definition of bronchiectasis? You will get $1 million when I find it. Anybody. And you don't have to necessarily give me a full definition. Yell out some things that happen with these patients. I just gave you one. The pus. All right, you're listening. Good job. What else? Abnormal widening. I like that. What else? Yes, I like that. Very good. What else? Productive cough for 6 months. You get a prize. Best one. That's awesome. Yes, productive cough. Okay, that abnormal widening and thickening of those airways. So when we look at what is bronchiectasis, it is the abnormal widening and thickening of those airways. It is also a progressive disease, chronic lung infections, okay? And it is progressive lung damage. That lung damage, once that occurs, that lung damage does not come back, right? It's not like a liver, it's nothing like that. It doesn't come back. We have damaged airways for life, okay? Do you guys have potholes here in Tennessee? Yes, right? We have potholes in Arizona as well. And do they ever get fixed? No. So they don't, right? They put this like weird gravel in there and they think that's good, but then you run over it and it's disgusting, okay? And you get flat tires and all that kind of stuff. So that happens inside of our lungs. I call it that potholing effect, okay? If it rains, how are we going to get rid of that? We are going to suck it out, right? You guys are really good at that. We're going to drive over it, some's going to fall out, or the sun is going to dry it out eventually, okay? But if you ever stick your hand in a pothole, I don't suggest this, especially if you come to Arizona, because we have really bad things like rattlesnakes, scorpions, gross, okay? Don't put your hand in there. But if you do, you're going to grab out a little bit of gunk and grime at the very bottom. It's never going to go away. That is what happens inside of these patients' lungs until we figure out a way to be able to suck it all the way out so we can go in and do a non-invasive procedure or an invasive procedure like a bronchoscopy, right, and get it all the way out. But it's never going to get far enough down to be able to fully get the entire pus out, okay? So we need other modalities that is going to help to push it out and for a patient to be able to cough it out, okay? So when we look at where we were with bronchiectasis, this is Cole's vicious cycle, very, very surrounding of the lungs, okay? We look at 4 different components. Where we are today, that 4 components does not change. The 4 components that you see up here are the same that we look at today. So when we look at airway inflammation. We heard talking about eosinophilic inflammation with our asthmatic patients, right? We are looking at inflammation, but it's a neutrophilic inflammation with our patients in bronchiectasis. So we look at airway destruction, we have impaired mucus clearance issues, and we have overall infection. So this all surrounding the lungs, right? So we also look at what's up on top there. It's called the initial insult. That initial insult is going to be very important for us to figure out where that happened. We may never figure out where this initial insult happened, but we have to try to figure out where the source is. So this is around the lungs. We love this. We are RTs. We're like, yes, everything around the lungs. But it's more complex than that, we know. So when we look at the vicious vortex, it is a complex disease. We are no longer, I don't know if we're making any progress in here, because when I look at Cole's vicious cycle, it sounds cute, right? It sounds great. Now we're at vicious vortex. That sounds terrible to me, but it is. It's a vortex. It's like a tornado, right? We don't know where everything is coming from. We don't know where it's coming from, when it's going to attack. It is a very complex disease. There are 4 pathological processes that happen, and all 4 of these have to be treated in order to treat this disease. It's a multimodality approach. So we can't just pick one of these to treat. We must pick all 4, okay? So when we look at impaired mucociliary clearance, that's that pus. We have to get that pus out. If we don't get that pus out, I can give antibiotic after antibiotic after antibiotic. It's not going to matter. We haven't got the breeding ground out enough for me to fix that infection, okay? So we have airway structural damage. We could do some surgery maybe, but it's damage. It's damage that's progressive. It's never going to go away. We have infection. We have to get those infections under control. And then we have airway inflammation. There is no medication outside of steroids, okay, that really tackle the inflammation in these patients. However, there are studies out there that suggest that inhaled corticosteroids are not good for patients with bronchiectasis. Can anybody tell me why? What do inhaled corticosteroids do to our bodies? They decrease the inflammation, right? Obviously, they're good for that, but they also decrease our immune system. These patients are extremely sick already. They have all this different bacteria involved. There's tons of studies out there that suggest that inhaled corticosteroids are not good for patients with bronchiectasis alone. However, in COPD, that has to be a judgment call, right? Because we know that they're good for patients with COPD. So we have to treat that. There is a new medication that is coming out that is going to be the first of its kind, and it's going to be the only medication on the market that is going to treat bronchiectasis. So we are making strides to help with this disease. So now, I give you a challenge. How many patients in the US do we think have bronchiectasis? I'm going to do the pause from this morning, not all at once. How many people? 1 million, 2 million, give me a number. How many? 4 million. Anybody else want to go higher? Anybody else want to go lower? It's like a game show. You might get a prize. You get a high five. Anybody else? 4.2 million. 4.2 million. You were very, very close. You might, I do this all over the country. You may have been the closest. So good job. So you were? I didn't hear you. You said it? 4.2? Oh, so you guys are tied. So you have to do rock, paper, scissors. So we have 4.2 million adults in the US that are undiagnosed and recognized, right? I said adults. This is a disease that does happen in pediatrics. Do not shy away from the peds population. I am a pediatric and NICU therapist. That's what I did. This is very much in fact, I just had an 8-year-old the other day that has been diagnosed with bronchiectasis, okay, progressive lung disease. Now, how many patients are we treating with this disease? So we know 4.2 million adults in the US have it. How many are we treating? You can redeem yourself. 100,000. Anybody want to go higher? Anybody want to go lower? 2,000? 200,000? Anybody want to go higher? If I went on that game show, I would do $1 every single time, because I feel like the $1 guy or girl always is like up there, right? You are almost correct, okay? About 500,000. 4.2 million have this disease, undiagnosed, unrecognized, but 500,000 patients are being treated. That's it. So we have a lot of work to do, right? Which gives you, as respiratory therapists, you guys can change this, okay? You can help with developing a bronchiectasis clinic, help with whatever within your hospital that helps to identify these patients, because the most important thing for these patients is early identification of this disease. So when we look at it, there are 3 types of bronchiectasis that we have. I didn't know this until I became an employee of a company that looks at bronchiectasis, right? So when we look at these normal CT scan, we look at we have a left and right main stem bronchi. It bifurcates into the left and right main stem, and then it gets smaller. All these little airways, right? They're kind of fat at the top, and then they get they have that distal tapering, if you will. We lose that when we have bronchiectasis. So when we look at this is called cylindrical or also tubular bronchiectasis. It is our most common type of bronchiectasis that we see. And you see that abnormal widening and thickening of those airways, right? We no longer, what did we lose there? At the very end, what did we lose? We lost that distal tapering, right? We no longer have that distal tapering happening. That distal tapering is natural for us to be able to have to stop things like pneumonia and atelectasis getting down in the bases of our airways, right? We don't want that. So we lose all that. That becomes really widened, and it gets harder and harder for mucus to come out. Then we have varicose. I know what I think of when I think of varicose. What do you guys think of? Varicose veins, right? You know that nasty, thick vein on the leg that if you poke it, all that stuff is coming out? That's what's happening inside of our lungs. So think of these patients. Now we start having that potholing effect happening. That potholing is now try to get it. Not only do we have abnormal widening and thickening, we have nasty, stinky mucus, and we also now have that potholing effect. So I call it bumpy roads. We got those bumpy roads now, and so it's going to be even harder and harder and harder for those patients to get that up and out. We have to get that out, though, somehow, because we're never going to break that vicious cycle. Okay? We look at cystic. I know what I think of. What do you guys think of? Cystic fibrosis, right? That's that natural honeycomb effect that you see on that CT scan. This person's really, really bad. Thank God for our patients, it's not as common. We're seeing a lot of research and things with the patients who have CF now, which is great to see that evolve, but we don't necessarily see this type as well. So CF is called genetic bronchiectasis. So genetic bronchiectasis does not mean that I am born with bronchiectasis. What it means is that I have a genetic factor, but we call it genetic bronchiectasis. Okay, and I'll talk about a couple other genetic diagnoses that will also fall into that category. But most of your CFers are going to have some form of bronchiectasis later on in their life, and it will be probably more than likely classified as cystic. So when we look at the symptoms of bronchiectasis, there's many symptoms of bronchiectasis. We said it, right? That chronic productive cough. These patients is what we're seeing already. You guys are dealing with them with your COPD population. You're seeing them with your asthmatics when they're under exacerbation, all this good stuff, okay? Or bad stuff. Chronic productive cough. The two things that you're gonna see with bronchiectasis patients are gonna be that green, nasty, stinky Pseudomonas, okay? Anybody in here like split pea soup? I just killed it for you, okay? No, I didn't, because we're a full room of respiratory therapists, so we don't care. The things that we talk about in the break room, y'all should laugh because you know I'm right. The things that we talk about, and then you go to the nursing and they're like, stop talking, that's gross, stop. And then you go to them and they're like, poop, and you're like, nope, I'm out, right? So we know that, okay? We know that we have that nasty, stinky, gross sputum. We do a really good job of sucking that out. We have hemoptysis, so that blood, that nastiness, okay? That's that due to that recurring infection, that chronic inflammation that these patients have. We have those repeated pulmonary infections. That is the cause of bronchiectasis, okay? That repeated pulmonary infection. So that initial insult does not have to come from any diagnosis of COPD or asthma. It could come from anything. It could be 2 bouts of pneumonia. It could be the flu. I am an asthmatic. I tend to get bronchitis twice a year, typically when the weather changes, okay? So that I am also a candidate for bronchiectasis. So it doesn't necessarily have to be that I have any type of chronic disease at all, which can be hard to determine. So when we look at, that's why it doesn't surround the lungs, because where does inflammation happen? Everywhere in the body. It doesn't just happen here, okay? Then we look at shortness of breath. These patients are hard. It's hard to breathe for these guys. We look at wheezing. They wheeze. And then we look at decreased activity, fatigue, and that overall chest discomfort. That chest discomfort happens a lot because of the abnormal widening and thickening of those airways. There's a lot of changes happening inside of that lung. Okay? But the causes of bronchiectasis, so there's genetic factors of bronchiectasis. So I talked about one. They told me not to stand that far close to the speaker. It's going to go, what? So I may do that just to see if you're all awake. I'm just kidding. So we have genetic factors, right? We have that cystic fibrosis patient. We have PCD, or that primary ciliary dyskinesia, and that Cartner's syndrome. PCD and Cartner's affects about 20% of all of our bronchiectasis patients. But again, it's not because they weren't born with bronchiectasis. They have a genetic factor that's going to lead to them. PCD and Cartner's syndrome affects what? The cilia, I can't talk today. The cilia, right? It affects that overall mucociliary escalator, so it does not allow that mucus, as it starts to get thick and gross, it does not allow that mucus to move up and out. In fact, therefore, they get more infection. That infection leads to bronchiectasis over time. Bronchiectasis does not have to be all over. It could be in a really, really small part of the lung at first, and that's why it's missed, right? They do this CT scan. So the gold standard for COPD, how do we diagnose? What's the gold standard for diagnosis of COPD today? PFT, right? So how do we diagnose bronchiectasis? A high-resolution CT scan, okay? The definitive diagnosis, high resolution. Everybody always argues with me, can I see it on a bronchoscopy? Can I see it on an x-ray? Maybe, but definitively to diagnose it, we have to have a high-resolution CT scan on file in order to make sure that it is there, okay? And again, it is missed quite often because it's not all over the lung. It's maybe just beginning in that little focal point down in the very bases of the lungs or somewhere else. We do CT scans. Most CT scans, they're not looking for bronchiectasis, or the radiologists haven't been told to rule it out, so they don't. What they do is they're looking for nodules or something else, okay? So it's missed often for many years. In fact, I was at the California Thoracic Society last year, and this doctor had a patient. He was a pulmonologist. It took him, can anybody guess how many scans it took before the patient got to him? 10, what did you say? 5? 9. 9 scans over a lot of years. He went back to all 9 of those scans, and guess what it showed? Bronchiectasis. Okay, so this patient has a progressive disease, has had to live with this because it has been consistently missed, consistently. So when we look at overall infectious, we have pneumonia, we have NTM, or that MAC infection, right? We have aspergillus. Do you guys see aspergillus very often out here? Sort of, yeah. We don't see it too much in Arizona, but we'll have, as people move from other parts, we see it a little bit more, but we're pretty dry. And then TB, obviously, and then those inflammatory diseases. This is crazy to me. Maybe I'm just a nerd. But this is huge. Inflammation. We're looking at things, look at that. We look at rheumatoid arthritis, ulcerative colitis, inflammatory bowel disease, Crohn's disease. You're all looking at me like, I'm an RT. This doesn't have anything to do with respiratory. But it does, because it's inflammation, okay? That inflammation, we are also looking at uncontrollable, non-treated GERD. Why would we be looking at GERD for these patients? What are they doing? They're silently aspirating, right? But because they're silently aspirating, that it becomes my initial insult. They may not have nothing. They may have no lung disease at all, but that initial insult is uncontrollable, years of GERD. They're silently aspirating. They come in, they have pneumonia twice a year. Now they have bronchiectasis. Now they have just got themselves a chronic progressive lung disease, right? It's very, very interesting at where this is shifting. Okay. We look at lung damage, and those are in bold because those are what we are mostly seeing, right? Our COPD and our asthma patients. I'm not telling you to go out there and be like, you have uncontrollable GERD, you got bronchiectasis, like Oprah, right? You got bronchiectasis, you got. We know that 4.2 million have it, okay? Just because they have GERD doesn't mean they have it. But if they're consistently coming in with Pseudomonas, that could be the initial insult of why it's going on. We have to go back. Sometimes we will never know. And 50% of bronchiectasis is idiopathic. We have no idea where it started. Okay, we'd have to go out. We could probably find that initial insult or why and what occurred, but 50% of it is idiopathic. So when we look at diagnosing it, it's CT scan. We must have that CT scan on file. Pulmonary function testing. We have to know what their baseline, right? These patients no longer have a normal baseline. They have a new normal baseline. We want to maintain and stabilize where they're at. Stabilizing of that lung function is going to give these patients the best outcome. And that becomes difficult, but that's what you guys are the expert at. How do we break that vicious cycle? Are we ever going to break exacerbations? I mean, if we do, you'll be a millionaire. If you can stop every single person from having an exacerbation, we're going to be rich, right? But the fact of the matter is that we know that it's not going to happen. So how do we prolong that next exacerbation from happening? What things can we do? How do we stop that from them getting, instead of 2 bouts of pneumonia, how do we stop it from 1 or none at all for the next 3 to 5 years? Because that's going to help when we look at their FEV1 and their FVC, that's going to help stabilize that lung function, and these patients will have a better quality of life, okay? Oops. So when we look at sputum cultures, I'm not going to get on a soapbox about sputum cultures, but how many of you still do them? Raise your hand high. Okay, quite a few of you. So I was out in Texas, and their Ann O'Donnell, she is a very, very passionate person, doctor when it comes to bronchiectasis. She was probably on her soapbox for like 20 minutes talking about sputum cultures. We were all like, whew. I'm on RT and I know more about sputum than I ever wanted to at this moment, right? Because we don't do them as often anymore. But we know that Pseudomonas and H. influenza is in these patients' sputum. We have to know what's growing in there. The only way to know that is by doing a sputum culture. They can show me, they can tell me, but we are gross. We like to see it. Well, I do. I don't know about you, but I like to see it. The patient at the bedside, they're like, look what I coughed off today. I get excited. Nobody else? Just me? Okay, I see some nods in there. And then our overall blood test, right? Blood testing, and we're doing more and more genetic blood testing because we have patients have autoimmune diseases. Autoimmune diseases have risen so high. So in April, I was diagnosed with celiac disease. Do you guys know what that is? So I have to eat nothing that has gluten in it, right? And I didn't know that. I didn't know that. I knew that I felt inflamed all the time. I knew that there was something going on, but I didn't know that I had celiac because it's also very underdiagnosed here in the United States. There's a ton of people who probably have it. So what I'm getting at with that is I now have an inflammatory disease. So I now have asthma and an inflammatory disease. Uh-oh. Right? I could definitely be that candidate. Even if you take that asthma away, I have a chronic inflammatory disease that I didn't know that I had. So on top of that, I get bronchitis twice a year. So there's a ton of initial insults. So if I go back to that vicious vortex, do you guys see where it's coming at now? It's a tornado. It's a complex disease that we have to attempt to try to figure out where it started and how to stop it. So there's so much money being poured into this disease, and you're going to start seeing that come to light, which I'm really, really excited about. When we look at bronchiectasis management, we have to manage all 4 of these diseases. It's a multi-modality approach. We cannot just treat one. We have to treat the infection. We have to treat the inflammation. And if they have bronchiectasis alone, what should I not be giving them? An ICS, right? They do have that combination. Most of these patients are missed because they have a combination of asthma, they have a combination of COPD, okay? The overlap syndromes are so big. In fact, this year I am very excited to present a poster presentation at the AARC. So I hope to see some of you out there because it goes over that overlap syndrome. So we took 114 patients, and out of that 114 patients, more than 50% of them had asthma. I was like, whoa. I thought it was going to be reversed, right? COPD, or they had a combination of all 3. So that's a huge thing to look at when we're looking at this disease, not just bronchiectasis alone, but a combination of the 3. Impaired mucociliary clearance. This is the hugest one. If the patient has bronchiectasis, we can identify that. The best way to help these patients progress and get better or stabilize that FEV1 and FVC on their PFT is by getting the pus out. We have to get that mucus out. If we don't, we're never going to break that cycle. It's going to be very, very difficult for us. And then that overall lung damage. So what is the correlation between bronchiectasis, NTM, and COPD? Well, bronchiectasis is not COPD. Got it? I do it with the kids at camp, right? If I see them using an inhaler without a spacer, I slap them, right? I don't really slap children. Don't go and tell everybody that. I was just talking about our insurance and how I never want to file for insurance ever again, right? So don't go tell people I slap children at camp. But it's true, right? Because we know if they use a spacer and blah, blah, blah. So it's the same. Bronchiectasis is not COPD. We need to stop classifying it as that. They have mucus. They have gross, sticky. Who should we be classifying them with? I heard it. Cystic fibrosis, okay? Every CF patient has some type of airway clearance on board to get that up and out. Why do they do that? Because they need to break the cycle, okay? They're breaking that cycle from them having that next infection. We have to do the same thing. And we have to obviously do it better than we're doing now because we're only treating 500,000 out of 4.2 that have it, okay? And when we look at that, they have more flare-ups. When we look at research released, about 8 to 30% of people with COPD have bronchiectasis. You're all looking at me like 8 to 30%. That's a huge range. The reason why it's such a huge range, there's not enough research. Okay? Last year or 2 years ago, there were over 20,000 research papers on COPD. How many do you think there was on bronchiectasis? 1? No, it was more than that. I hope. So there was around 6,000, okay? So, and it's not a lot, okay? Knowing that this is primary diagnosis that's helping. You guys see these patients, right? They're frequent flyers. They're not very, they're hard to work with at times, but these are those patients. So when we classify it as COPD, we're treating the COPD when really the underlying cause is bronchiectasis, okay? It has to come up. It has to come up more and more. If you have any ideas of how to do that, I'd love to talk to you. When we look at that, they have more flare-ups and they cost us more money, right? Because they not only end up in our floors and in our clinics, they end up in our ICUs, on our vents, and that becomes very, very expensive. I always talk about how much we're paying for a Big Mac nowadays, right? It's ridiculously expensive. Groceries are expensive. Everything is so expensive. So these patients are costing us more every single day. The healthcare utilization has gone up and it's continuing to go up. This disease is actually going up by about 8%, and some studies show around 10 to 12% increase every single year and we're not stopping it. It's continuing to grow. When we think of, I argued with a doctor about COVID, right? Because it's dry, right? Oh, they have a dry cough, nothing's happening. I was like, I don't know, when I suck them out, I'm getting a lot of stuff. But they're now they have damaged lungs, right? Their lungs are damaged, they have long-term effects from this disease, and now what's happening is they have that initial insult. COVID was the initial insult, they now have damaged lungs, they're getting sick over and over and over again. They're calling it traction bronchiectasis, which is slightly different than the bronchiectasis, but I call it like asthma-induced, exercise-induced asthma, right? It's asthma, so let's figure out how to treat it. We have to get that pus out. Very, very important. So when we look at the correlation and the overlap, you can see this overlap. The overlap with COPD, you can see that asthma, so we have ACOS, which is COPD and asthma together, and you can see bronchiectasis really, really small down there. My hope is that that circle gets bigger as we start to look at this disease a little bit better. So when we look at this, how do we know that the patients with bronchiectasis or patients with COPD have bronchiectasis? Well, this is a study. It was a COSMOS study. It's 855 patients, so a very large study. It was done in 2016 at Chest, so you can say it's really, really old, right? It is, and it's probably more prevalent today than it was back in 2016, knowing what we've all seen. So when we look at it, we have 4 stages of COPD, right? Stage 4 being the worst. At what point do our patients typically, at what stage do they get diagnosed with COPD? 3, right? Yeah, so 3. And what's the average age? 60s, right? The 60-60 club. So it's the same with bronchiectasis. Average age is about 65 when they get it, so they fall under that same range of becoming that COPD population. But stage 1, we don't have very many patients that get diagnosed at stage 1, but in this study they looked at all 4 of those stages, and even at 25%, found that they had undiagnosed and recognized bronchiectasis in stage 1. I know patients who don't even know what COPD stands for. They're in stage 1, they're like, I'm out playing golf still, what are you all talking about? Now they have 2 progressive diseases that we're trying to combat and fight with, right? That's really important, and as you can see, it gets higher and higher and higher as we go through the stages. In stage 4, there was a limited amount of patients that made it to stage 4. Why? They died, right? They died. So these patients not only are dying faster and quicker, now we have a stage 1 patient with 25% of those patients being undiagnosed and unrecognized. That's huge. That's huge. They have overlap symptoms. They're chronic cough. They have a shortness of breath. All those things. Are these patients that you see on a regular basis? They are, right? They're your frequent flyers. They're your frequent flyers. So when we look at identification of BCOS, we need to look at what do they have. Are they coming in with green, nasty sputum, or do they have H. influenza? Do they have NTM? Do they have MAC? Am I seeing this in their sputum when I'm doing these cultures? If the answer is yes, and you say, hey, Mr. Smith, he has come in twice this year for Pseudomonas, what's going on? Be thinking of bronchiectasis as hopefully you'll think of this, and you'll be like, ooh, bronchiectasis. The light bulb went off and said, maybe we can look at the CT scan. Maybe they already have it, and we're not treating for it, or maybe it wasn't talked about, okay? So when we look at overall NTM, this is in our water and this is in our soil. So all of us are showering in this, it's in our water that we drink, but for those, it's an opportunistic bacteria. So for those of us that don't have any type of lung disease, we don't care about this, right? It's not affecting us. But those patients with bronchiectasis, it's absolutely affecting them. We have a patient that lives out in New York. She literally changes out her shower head like twice per year, buys a new one, and then is constantly cleaning everything because she is now prone to having this. When I talk about MAC infections, can anybody in here tell me how long it takes to get rid of a MAC infection? Forever. I like that answer because she's right. It can take 2 to 3 years for us even to figure out what type of antibiotic to put these patients on that work. It takes forever. And then what happens to our patients? They become resistant, right? Overabundance of antibiotic usage with these patients is so bad, but we have to fight all 4 of them, right? So it's a multimodality approach. What do we give for patients with infection? We're giving them antibiotics, but they become harder and harder to treat as we try to identify what's going on. And if they've had it, they become resistant. We know that. So it's really, really important that we are looking at this overall complexity in this. So MAC infections are a big thing. When we look at the clinical financial burden, like I said, it costs us a bunch of money. So when we look at that clinical burden, with bronchiectasis only, we look at about 5,000, a little just over 5,000 $5,000 that we save. COPD, about 6,000 and more. And then when we look at BCOS, it's almost double that. So we are, and if you think about it, like, right, I mean, when I talked about this before, I was saying like around $5,000, $10,000. That doesn't seem like a lot because I said we're paying like $1 bazillion for a Big Mac nowadays. But when we look at how many patients have it, and what was that number? 4.2 million, right? If we take that 15,000 and we multiply that by how many times they've been in the hospital, how many times they've been to their clinic, what we're giving them, that is a lot of money we are missing. We are missing a ton of money that it's costing us and how we utilize what we have. So airway clearance therapy. Airway clearance therapy is going to be the key to getting that pus out for these patients, and the right airway clearance therapy. So when we look at the goals of airway clearance therapy, it hasn't changed. The AARC defined this. It's the same as it was 10 years ago, right? It really hasn't changed. It's been around. How many of you in here still do manual CPT? Are you the only one? Was anybody else doing manual CPT? Are you? Okay, good for you. I used to get fired all the time. I needed to go to, you can't do it consistently effective 100% of the time, all the time, right? Or maybe you guys can, and that's awesome. But I could not. I remember getting fired I still remember him today, and I still follow him and talk to the CFer who fired me. And it's sad, right? You're like, dang. Failed that day. But really, it's really, 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 really difficult to do on a consistent, effective therapy all the time, right? And then when we're doing it, we learned how to do it, we trained how to do it. Who's doing it consistent, effective at home? That is a big question, right? At home. So we want to improve the overall symptoms. We want to reduce exacerbations. We want to preserve their lung function and improve quality of life. I don't know why you guys got into being a respiratory therapist, but I became a respiratory therapist to do those things right there. I want to help preserve the lung function of those patients. I've gone through it my entire life, being an uncontrolled asthmatic. It's been very, very difficult for me, so I want to not only preserve their life, but I want to improve their overall quality of life. Knowing that these patients are going to succumb to this disease or a comorbidity of these diseases, it's hard, right? It's hard to think about, and we see these patients on a daily basis. So when we look at different types of techniques, we have breathing techniques, overall CPT, that manual, all this stuff still works, right? High frequency chest wall oscillation or vest therapy, we have mucolytics, we have OPEP devices, all of this. And right now, I always talk to doctors and they're like, well, which one's the best? Maybe a combo of all of them, right? Patients aren't apples to apples. So when we look at the right airway clearance therapy, not necessarily do I want to take that OPEP away from them if I'm putting them on a high frequency chest wall oscillation device. Maybe they need both, okay? Let's look at that and figure out how do we choose the right device. So when we look at high frequency chest wall oscillation, there are many, many devices out there. There are devices that are portable. There are devices most devices have the garment, right? They connect to a hose or hoses, and they connect to a generator. What it does is it shear thins and propels that mucus. So that shearing and that thinning is important, right? We want that to happen, but we also need that propelling factor because we have to get that pus out. I told you about those potholes. If we don't have that propelling factor, or the device doesn't have a way to propel that mucus into the upper airway without postural drainage, we're never going to be effective. We can shear and we can thin it all day long, but unless we get it up here, my patients, 65-year-old patient that probably have a combination of COPD and bronchiectasis, do they have a strong cough? Do they have a good, effective diaphragm that's working properly? No, right? They do not. So that propelling factor in getting it here is going to make it more beneficial for me to be able to get it up and out. So when you're choosing the right device, compliance, what are they going to use? In fact, when I went to a patient's home, I saw the pickle. Everybody know what the pickle is? Okay, most people don't. The younger, they're like, what's the pickle? I'm like, what are you talking about? We all know, right? That OPEP, that PEP device. I saw a lady, it does look like a vase. She had flowers in it. This is a true story. I was like, it does look like a vase, kind of, when you stand it up. But that's not what it's for, right? So obviously her compliance was not here. It was not here, it was here, right? She wasn't using it. And there's other factors, right? Can the patient put their mouth around it? Can they even have the expiratory or inspiratory flow to be able to do any of this stuff? The answer, maybe no, right? And that's something we have to consistently check on, and you guys are good at coaching to that. But when we look at this, that shearing, that thinning, and that propelling, we have to get that up, and we have to break it up to be able to get it up and out. So high frequency chest wall oscillation, how do we know that it works? It works because it's been researched. It's been around for a long time. It was a device that was made for a cystic fibrosis population because they had that thick, gross, nasty mucus, right? So we do know with the bronchiectasis registry now, there is a bunch of clinics and hospitals that are now signing up for this bronchiectasis registry. That's going to be really important to follow and see what happens within the future. So when we look at this, we look at 54% of those patients had a severe BSI of severe, very, very severe before. 81.4% within the past 2 years, they had an exacerbation. Most of these patients not only have one, but they'll have multiple exacerbations per year, whether that meant they went to the hospital or not. There was an exacerbation that happened. And then when it looks like were they compliant? So these patients, when we looked at overall outcomes with it, they were compliant, okay? We saw a 57% reduction in antibiotic. That is huge. We also saw a 59 to 82% decrease in that hospitalization. So these patients weren't going to the hospital as often. And that overall improvement in stabilization of that lung function was huge. That quality of life, when this study was done, most patients are asked, did it improve your quality of life? These patients were not. So there was over 60% of these patients that just reported a significant improvement in their quality of life without even being asked. That's huge because they were on the right therapy. Minimal effort for a patient on high frequency chest wall oscillation. Minimal because we have, patients that go home, they're on, they have an RT that goes to the house, they set all that stuff up for them, and they're pretty compliant with it because they usually will follow those patients to make sure compliance happens. You can't say that for all of the devices, but again, choosing the right therapy and a combination of all the therapies, what is going to work for that patient and for how long is it going to work? So when we look at that overall continuum of care, I am the most passionate about hospital to home, and I'll tell you the reason why here in a second. How often, so if the patient comes in for an exacerbation, we tell them to go follow up, if they have a pulmonologist, right? Follow up with your pulmonologist or follow up with your PCP. They go to their PCP. If they don't have a pulmonologist, how long is it taking for them to get to a pulmonologist? Give me an average days, weeks, months. I heard 6 months. Anybody else? You guys are right, 6 months to 9 months. So patients it's taking longer and longer, right? We're seeing a drastic shift in the amount of specialists we have in this country, and we can't get the doctors out fast enough, right, with a specialty. So a lot of our patients are being seen by our PCPs. PCPs know this much, and they'll tell you that. They are not scared to say, I didn't learn much about this disease, I'm trying to manage this, especially during COVID, right? Because where did our pulmonologists go? They went into the hospital. So these patients being managed at home had to be managed by our PCP population. And so they learned more and more, but it's still being missed. It's still being missed, or we wouldn't have 4.2 million in a habit. So hospital to home, if they're using airway clearance therapy, they're going to be compliant, it's working, they're using high frequency chest wall oscillation in the hospital, suggest it for home. How many of you, any case manager RTs in here? No? Okay. And do you guys work closely with case management? Anybody? Yes? Okay. Yay. I encourage it, okay? I encourage it. UC Davis has a fantastic program if anybody wants to know how to start it. But respiratory therapists, you guys, I love to empower RTs. You are key to this disease and how we stop this. You really are. You see these patients all the time. Get more involved in taking a look at this disease and how you can benefit them. But getting them on the right therapy is so important. And the only way to do that is to shear thin and propel that mucus into the upper airway. Oops. So when we look at this, it has to be the right. That discharge planning, that case management is important. So if you're not involved in that, you absolutely should be involved in that process, okay? I believe in you. So when we look at suspecting of bronchiectasis, this is all a jumble, right? I said it's a complex disease. So we have to think of all things that could be trickling down. So if I have an unexplained chronic cough, I should be thinking bronchiectasis. If I have a daily productive cough or purulent sputum, that green nasty sputum, that Pseudomonas, that H influenza, if I can see that on their sputum culture, I need to be thinking that they have bronchiectasis, suspecting of that. Reoccurring bronchitis or any type of respiratory infection. They come in for multiple respiratory infections per year. Let's rule it out, right? High resolution CT scan, we can rule out bronchiectasis. Moderate to severe COPD or asthma, or any type of frequent exacerbation. That's a ton of our patients, right? We have those frequent flyers. Colonized Pseudomonas, NTM, that Aspergillus, NTM or MAC is huge with these patients. We should be suspecting bronchiectasis. Hemoptysis, if they're coughing up blood and there's no other source as to why they're coughing up that blood, we should suspect bronchiectasis. Relentless fatigue of unknown cause. They're tired. They have this fatigue. Obviously, most of the time they're going to have other things that are coupling this, but if they have relentless fatigue of unknown cause, suspect it, okay? Persistent cough in patients with risk factors. This is going to be huge. We are going to start seeing this. In fact, I'm working with a doctor in Texas right now who is looking at GERD. It's really, 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 really bad. So we look at rheumatoid arthritis. As we start to see irritable bowel syndrome, all those things with inflammatory diseases, we hear inflammation a lot because of biologics, right? So all these biologics have come to play, and we hear this chronic inflammation. If I can decrease the inflammation, I can decrease what's happening with the patient. In bronchiectasis, it's much more complex than that. It's much more. When the new drug comes out, decreasing that inflammation is going to be, it's going to be huge for these patients, but it's not going to get the mucus out. We have to figure out still how to get that mucus out, and the best way is through using high-frequency chest wall oscillation for these patients. That is it. Whew, we made it, okay? Some of these key learnings, bronchiectasis is progressive. It's a chronic disease. It's not going away, okay? There is going to be new bronchiectasis guidelines coming out in the US. Yes! I feel like, have you seen that meme where she's like, superstar? I feel like doing that when I hear it because I'm so excited for these guidelines. This is going to really, really help us to be able to identify it. Early identification of this disease is going to be so important. And then treatment of that multimodality approach. So these patients cannot just be on antibiotics. They have to be on other things. You have to treat it. All four of those components must be treated to break that cycle. And then the right airway clearance device is so crucial. Not only, I always say the best device is the one the patient's going to use and continue to use, right? And the one that the patient likes to use, and they're going to see those outcomes. If we see those outcomes, you see those outcomes, patients see outcomes, and improvement of quality of life goes up, okay? I didn't know who was all going to be in the audience. I just know I saw respiratory nursing and sleep. So I wanted to end today by not only saying thank you to Encore, and this is an amazing event, and you guys are extremely lucky to have it here in the area. So thank you for letting me come and speak. I really, really appreciate it. And so I have this one here. Your patient is in room 4, is throwing poo and ripping out their IVs, but that's none of my business. I'm an RT. Call me if they stop breathing. Okay? I mean, I don't know. I worked in the NICU. I used to change poopy diapers all the time, and it was fine, but adults, my nurse back there, me and you, best friends, right? So I didn't know if we had any sleep, but nobody knows the horrors of this, you know, putting the stuff on all the patient's head. You want no hair over here, right, to come in. That's the best type of patient to stick those on. And then when it's time to go, but you still have to document. I think of my nurses because I tell you, the nurses, they are there until 8 or 9 o'clock documenting all the time. I feel so bad for them at times when I see them, but God bless all of you. Thank you so much for allowing me to come speak and share my week with you. I really appreciate it. Thank you. If you have any questions or want to talk more, I do have my email up here. Please feel free to reach out to me at any time.
We do have time for questions. We have 10 minutes before our next speaker is scheduled to start, and we're also waiting for the RTs in the sleep room to come over. So we have about 10 minutes if y'all have any questions.
So somebody better ask me a question.
So come on. So his question was, who is publishing the new guidelines and when are they coming out?
So it's going to be a group of bronchiectasis specialists that are working on it now. So I can give you Dr. Basavaraj out in NYU Langone, Dr. Solomon out at University of Alabama, Birmingham. So they are, I would assume that it would be chest is who they're really working with on this, and then obviously working closely with the European folks to kind of see what they do, what's working, what's not, what will work here in the US, what won't, and then they'll go from there. So I don't know when they're going to come out, but I've heard maybe we'll have a glimpse next year. Yep.
Good question. Thanks, Roger. Anybody else have a question?
You can ask me anything. What is
Sorry,
it?
we couldn't hear you.
The disc. Oh, yeah. Forgot about that. What do you guys think I am? Y'all are really good. That's exactly where I am.
The audience at home didn't hear.
Oh, they asked me what my disc was.
Okay.
Yes, and I am an I to the T. To the T. Life of the party, right? Anybody going to AARC? Anybody want to party with me? Woo, let's go. Right? So a lot of fun. I have, I'm always open to having great conversations. I want to know what you're doing out in the field and how we can help support you. I want to empower respiratory therapists. We could do so much more. We are amazing, and I just love being an RT. So.
Awesome. Anything else? And I've heard many lectures on bronchiectasis, but this one held my attention.
Good. I'm glad.
Because, we have this green, pussy, smelly yuck that we suck. And you are great. Thank you so much.
Thank you.
Thank her again.
I usually like to do the sound, the sound of, there you go. You got it down pat.
Okay.
Good for you.